In this video, we introduce our work titled Recovery is Relational: Digital Support Needs for Patients and Supporters in Eating Disorder Recovery. Eating disorders are mental health conditions characterized by disrupted eating behaviors, such as restriction, binge eating, or purging. They significantly affect not only physical health, but also everyday life and relationships. Many of the most challenging moments in recovery occur in daily life, for example, before meals, when alone, or after eating. These are moments where support is often needed but not always available. While individuals may receive treatment, professional care is episodic and cannot continuously support these moments. This has led to growing interest in both digital health interventions and social support. Tools like self-tracking apps and conversational agents, along with family, partners, and friends, aim to provide support in everyday contexts. However, providing effective support in everyday life remains challenging. We still have limited empirical understanding of when support is needed, how it should be delivered, and how patients and supporters navigate support together. To address this, we conducted a study capturing perspectives from both sides of the support relationship. We recruited 27 individuals with eating disorders and 12 social supporters covering various ED types and relationships. Importantly, we asked participants about both the support they need for themselves and the support they believe others need. In detail, our study consisted of two main stages. Due to time constraints, I will focus on the in situ diary study. We aim to capture how support needs unfold as they arise in everyday life. To do this, we conducted a 2-week in situ diary study. During this period, participants recorded real-life situations where they needed support along with the surrounding context. In the diary study, participants recorded contextual details using a custom-built mobile app. This allowed us to capture support needs as they occurred, with more consistent reporting than retrospective methods. I will skip the details of the analysis in this video. From our study, we found that support is needed not only during disordered eating behaviors, but also in the moments before and after. Before these behaviors, participants often described moments of vulnerability such as anxiety around meals, strong urges to binge or purge, and persistent preoccupation with body image and food. These experiences disrupted their everyday functioning. In these pre-episode moments, they sought different types of support depending on the context. Most commonly, they wanted instrumental and physical support that could interrupt escalating urges. On the other hand, after disordered eating behaviors, participants often experienced emotional crashes and physical discomfort. In these post-episode moments, they sought support that could help them recover both emotionally and physically and regain a sense of motivation to continue their recovery. Taken together, this finding highlights that support needs extend beyond the episode itself, spanning critical windows before and after. However, prior HCI work has largely focused on in-the-moment or preventative interventions, often overlooking these surrounding phases, especially post-episode recovery. Our findings suggest that these moments are not peripheral, but critical moments where timely support is needed. Therefore, we encourage researchers and designers to more closely investigate these moments and develop interventions that can support individuals across the full trajectory of these experiences. We also found that patients and social supporters often share an understanding of when support might be needed and what kind of support could be helpful. However, this shared awareness does not always translate into smooth, supportive interactions. A key reason for this is that both struggles and recovery progress often go unnoticed between them. Many eating disorder-related experiences are internal, such as urges, anxiety, or cognitive preoccupation, and are not visible on the surface. For example, even when a patient is experiencing a strong urge to binge eat, unless it is expressed or acted upon, it is difficult for supporters to recognize it. These invisible struggles naturally lead to a lack of legibility, where supporters cannot interpret what is happening as a signal for support. More importantly, even when something becomes visible, it is not always legible as a cue for action. For instance, a supporter might notice that a patient is binge eating, but still struggle to determine whether it is the right moment to offer support, and if so, what kind of support would be appropriate. As a result, when struggles are not legible, supporters often rely on delayed signals, such as visible behavioral changes or explicit requests. But by the time these signals appear, the moment when support is most needed may have already passed. This leads to misalignment in both when and what support is provided. Many participants described how such misalignment creates relational tension, even when both sides genuinely care about each other. Patients often respond by withdrawing or masking their struggles to avoid burdening others. For example, one participant explained that she avoided seeking help because she did not want to add to others' burdens. This pattern was also visible to supporters. One supporter reflected that the patient kept trying to hide her challenges. In contrast, supporters often respond in the opposite direction by intensifying their efforts. When they sense that something is wrong but cannot clearly interpret it, they try additional strategies and become more involved in the care process. Taken together, these findings highlight that the challenge is not a lack of willingness to support but a lack of legibility in patient struggles. While I focus on struggles here, we also observe that recovery progress often remains unrecognized, leading to missed opportunities for encouragement. This suggests opportunities to support the legibility of internal struggles and small recovery progress so that support can be delivered in a more timely and aligned way. We have many more empirical findings on support needs in eating disorder recovery, considering both patients' and informal supporters' perspectives, as well as insights into the design of digital interventions. First, a shift from focusing on the individual to supporting the broader relational ecosystem. Second, a shift from support that primarily happens after the fact, such as self-tracking and reflection, to support that spans pre, in, and post moments of vulnerability in everyday life. Third, a shift from relying only on self-report to incorporating contextual and relational signals. And finally, a shift from tracking symptoms to supporting coordination and mediation within care networks. This concludes my presentation. Thank you.